I'm Dr. Jeffrey Tunick. I'm the Educational and Clinical Director for the Solutions Stem Cell Clinic in Vancouver. It's my pleasure to be your presenter today. We're really glad to see so many of you here. We're really packed. It's great. We have a lot of great information to share with you today. Let me just say a couple of words about Solutions itself. We are a participating clinic in what's called the Cell Surgical Network. Cell Surgical Network is the largest group of stem cell clinics in the United States. There are affiliated Cell Surgical Network clinics in Sequim, in Seattle, in Bellevue, in Tacoma, Anchorage, Alaska, and the Solutions Clinic here in Vancouver. And as a group, we have performed and continue to perform the largest number of stem cell therapy procedures in the Pacific Northwest. So we're all here for the Stem Cell Therapy seminar, hopefully. How many of you guys have actually heard of stem cells? I guess a lot of you, otherwise you wouldn't be here, right? Has anybody had them done? Okay, so today we're going to talk about the different types of stem cells, how they work, where they come from, how they're harvested, how they're deployed, what kind of conditions they cover. Hopefully we're going to answer every question you ever had about stem cells, maybe even give you a little more about that. Usually people come to one of these kind of lectures because either they're just intellectually fascinated and interested to learn about it. And if that's why you're here, you're going to really get your money's worth today. Some of you may be here because of a loved one or a friend, and some of you may have your own particular health challenges that you're concerned about. You're wondering whether stem cells could potentially do something for you, and I promise you we'll try to answer all those questions today. And for those of you who do learn something positive and you think it might be a benefit for you, hopefully it can change your life today. I just want to make some comments about the seminar itself. It's an educational program. It's not meant to provide individual medical advice for anyone here today. Because of that, we're more than happy to offer a free consultation. We'll talk more about that at the end. But if you want to meet, after you're done with this, if you want to meet with us on an individual basis to discuss your own needs, we'll be able to provide that at the end of the program. So I'd like to start the program with a 2.5-minute video trailer about a movie about stem cells, our combat veterans, and how stem cell therapy produced positive changes in people's lives. So I'm sorry I don't have popcorn for you guys. Did anybody bring popcorn? No? Okay, I'm sorry I don't have popcorn for you.
My dad is Roger. He has been in the military my whole life. He helps people. I love my dad, so whatever my dad is a part of, I am a part of that as well.
Oz, my son, he's got permanent brain damage, like a hypoxic brain injury now. I'm the world to him, so like my ability to go and play baseball is directly to his benefit. But my odometer's really rolled over. I need an engine replacement, and there's been a long life of wear and tear. Despite what you see in the movies or what you might imagine, you know, people in combat die horribly.
Whoa!
Hey, there it is. There we are. That's a flood of memories, huh? You got shot in the damn head and you climb back in the monkey rig.
I heard it hit, and when it hit, it was like the sound of a garbage bag full of wet diapers just being flung against a brick wall at like 100 miles an hour. If the pain on my face could go from an 8 down to a 7, I could go through a whole night of sleep. Or just being able to throw on a pair of running shoes and just go for a jog.
The things you're talking about are not lofty goals.
I tell these stem cell guys, I tell everybody, I'm like, I'm in this because it's enriching my life and the people in my life.
You know, the fact that you could literally take your own stem cells and bank them and have them available for the future whenever something comes on, to have that ability to heal yourself with your own cells is amazing.
Let's see
your
it.
cardio routine, bro.
Let's see it. Think about, oh.
What the heck? We're calling that the John Travolta.
It improves gross motor, it improves fine motor. Those are things we struggle with. If there's something that could help my son coordinate his actions better to be more independent, it's a hope that wasn't there.
He's nonverbal, but he's very cognitive and does everything he can to communicate. To increase that by 1%, his ability to interact with the world, we need to just dramatically improve his life. It's very important when you go in to see your boss that you look him in the eye, you shake his hand, and you say what?
Boss.
Well, you say, hi, boss.
Boss.
That's right, man.
That's good.
That's it.
I didn't expect this pain to ever go away. I mean, if you guys don't do anything else for the rest of your lives, I think this is a victory you can hang your hat on, and for the rest of your days, look back and be proud of it. I don't even know know how to verbalize how powerful this is.
Us as combat veterans, we have to find ways forward. We have to involve our families directly in the things that we're passionate about. The challenge is to come back to ourselves and come back to our own humanity. Whoa!
You guys enjoy that?
Yes.
Yeah. Master Sergeant Roger Sparks, who's the dad in the film, and his 12-year-old son Oz, who was brain damaged and has cerebral palsy, them and their friends have been instrumental in introducing us to the Veterans Administration, and Solutions and its sister clinics are now involved in a nationwide program where we're going to be providing stem cell treatment to combat vets who are suffering from PTSD and TBI, and we're real excited about that. Roger is the vet that you saw in the movie, and Oz, the 12-year-old. And I had the opportunity to meet Oz some months back, and I was at a conference in California, and suddenly there was Oz, who I had seen the video of, and he was just walking across the ballroom floor, you know, with a normal gait, and it really caught my eye. I was like, wow. Isn't that the kid with CP? So that was really very interesting, and that was about 8 days after you saw the harvest of Oz's stem cells in the video. So very, very interesting. It's going to be a full-length movie that's going to be available soon. If you ever have the opportunity to watch the entire movie, I hope you'll take advantage of it. So like I said, Solutions is part of the Cell Surgical Network, and we're affiliated with clinics all over the country. And we're going to be happy to help educate you guys today and tell you everything you wanted to know. Hopefully you've all had a chance to look at this little survey that's sitting in front of you. Can I just have a show of hands of how many people have had incidences where they have problems with their knees, for example? I just want to get a sense of who I'm talking with today. Okay, great. And how about hips? Okay, shoulders? Okay, great. So we're going to cover a lot of stuff we'll use to talk about the orthopedics, and it'll really help you understand really well what stem cells can really do. But we'll also talk about systemic diseases and autoimmune diseases. We'll cover all that ground. But just in focusing in on you guys as a group, anybody had their issue for like more than 15 years? Yeah, wow, isn't that something? How about more than 10? Okay, 5? Wow. Year. I don't know about you guys, but for me, if it's more than a week, you know, I'm not happy. I'm not a happy camper. You know, so how often do you get it? Is it something that hits you every single day? Is it twice a week? Is it twice a month? You know, if it's once a year, okay, life happens, right? But if it's more frequent than that, it really starts to bug us. Every day, right? Isn't that something? I mean, it's all, and I'm just going to use a little phrase today, quality of life, and that's really what this is all about today. We're going to talk about quality of life and what we can do about it. So when it's at its worst, if you guys had the chance to fill out one of those pain questionnaires at your doctor's office from 0 to 10, right? And you guys have 11, right? Yeah. You know, it's interesting because at its worst, you might say, you know, if I asked you, you might say my pain's an 8. Okay, when it's at its worst, it's an 8. And if I said to you, when is it at its best? You may say a 4. So if it was a 4, how has your quality of life been impacted? You probably have stopped doing some of the things you like to do. Like I'm a cyclist, okay? I love to cycle. But you know what? If I'm really not doing so well, I'm probably going to give that up, right? So I'm living my life, but I'm giving stuff up. And so people get discouraged, and people get told by doctors that we have to learn to live with it. Have you guys been told that? Yeah. Does that anger the living that Jesus had you? Yeah, it does, right? You got to learn to live with it. It's your old age. Okay, confession time. I'm 72, okay? I'm a young 72, but I'm still 72, right? So if the doctor says to me, well, you have to learn to live with it, it's just part of life, you know, whatever, I'm not so happy with that. So what we're going to do today in this educational seminar is we're going to make a comparison between what I'm going to refer to as traditional degenerative approaches to pain and suffering versus regenerative approaches, okay? So we're going to compare the two. We'll go back and forth a little bit. But I need to bring you all up to speed, and I need to turn you guys into a radiologist, okay? You guys ready to become radiologists? All right, great. So this is an x-ray of my right knee, let's say, as I stand in front of you. And this is the bone in my thigh, the femur bone. and this is in my lower leg. This is the tibia and the fibula, and this is the space where the cartilage is, that oftentimes referred to as the meniscus, okay? So this is a normal joint, original equipment. I call it the Superman knee, and it's original equipment, and when I was 12 years old, I could do just about anything. I was immortal. How many people here were 12 at one time? So we all experienced immortality together. When we were 12, we could do just about anything. We could climb up a tree, fall out of it, fall off our bike, scrape the heck out of ourselves, and just get right back up and go. We were great, okay? But let's say that as I've been living my life, as all of us have been going along, we start to get a little bit of pain in that knee. It's really starting to bug me. So what do I start to do generally? My first order of defense is I go for the ice. Maybe I go for some over-the-counter pain meds. I'm trying to do good. Maybe I've even succumbed to, I found a bottle of muscle relaxants in the cabinet, and I tried some of those, even though they all have side effects like addiction, drowsiness, dizziness, changes in vision and headache, clumsiness, all that good stuff, right? We all know that meds in general all have some side effects. But let's say that worked for a while, but after a while it stopped working, and the knee was just bugging. So I go to the doc, and we take another x-ray. All right, so you guys are all radiologists now. I want you to go back real fast to the first one. Okay? Keep that in your mind's eye for a second. Here we go. Ready? Here we are. So, look at the joint space now. Does it look the same? No, it's less on one side. So the cartilage has started to degenerate over time. It started to soften. It's unable to take the same amount of impact that it always was able to when we were immortal, and it's starting to bug me. So what do we do now? What do you think? We start taking some medicine, right? We reach for something a little bit stronger, right? So maybe we hit the pain pills now, the good old painkillers, and all of which you know have all kinds of side effects that come along with them. And has anybody here not heard of the opioid crisis in the United States? Okay, so we're all aware of it, okay? We're all adults, we all know about it, but oftentimes that's what we do. We jump right over to that, or maybe we go to the anti-inflammatory, maybe we go get a bottle of ibuprofen at Costco. How many of you guys buy that big bottle of ibuprofen? Is that a 30-day supply? Sometimes it gets like that, right? It's like, what the heck? God, I gotta get that gigantic bottle because I'm gonna really need it. But we all know there's a lot of downside risks to that too, okay? So maybe the doctor's written us a prescription for a high-potency anti-inflammatory like Celebrex, but they all carry downside. And that's what I want you guys to get into your heads about this degenerative process that's happening and the degenerative way that we're treating it, because regardless of the care that we're providing, the knee is continuing over time to degenerate. So now the ibuprofen and the other stuff has stopped working. My knee, I just got back from hiking Silver Falls down in Oregon, and my knee is just really unhappy. So I go back to the doc, and we get a follow-up x-ray, and now look at it. I know you guys are all radiologists. What do you think? It's further degenerated, isn't it? It's gone further down that pathway. So not so good. So now large sections of the cartilage have worn out, and it's not really able to take the impact that I keep putting on it when I'm going up and down the trail, right? So what does the doc do? When I go to the doc, what does he do? Okay, physical therapy up here. What do you guys think? Cortisone. Cortisone, all right, great. All right, so cortisone, right? So what's the protocol for cortisone? How many cortisone injections can you get?
3 a year.
3, is that 3 a week, 3 a year?
Yeah.
3 a year, 3 a year, okay? And it's not 3 in the left shoulder, 3 in the right shoulder, 3 in the left knee, 3 in the right knee. It's 3 total for a period of 1 year, okay? Now, cortisone is a really powerful anti-inflammatory. So let's say I had that first cortisone shot, and I go, wow, boy, that's terrific. Thanks, doc. Boy, my knee's great. So let's say it lasted for 4 months. But after a while, the cortisone wears off, and I'm back in there for a second shot. How's the second one? Does it help as much as the first? Probably not, right? But I'm only allowed 3. So the human condition says that I'm going to wait for that third one as long as I possibly can, because it's the only one I have left. So when I finally decide to have the last one, does it help? What do you think? Probably not, right? Okay. So what are the side effects of cortisone? Anybody know? This is my favorite one.
Makes you gain weight.
It does that too. But I want you to think about this. It contributes 8% bone loss in 4 months, and you get 3 of them in the course of a year. All right? So this is part of my displeasure with cortisone steroidal injections into any joint. All right? Now, again, this goes with that line of thinking of the degenerative process. How are we managing a patient's degenerative process? The knee is continuing to get worse over a period of time. The patient is back complaining of pain, and he just can't have the same functional capacity he had, and he's asking for help. So that's why we're doing it. But it's got a ton of side effects, doesn't it? You see the sign? You see where it says elevated blood sugar? We heard a case up in Seattle this past year with a firefighter. His doc, for some reason, thought he could have 3 injections a month. Not a great idea, right? So at the end of that year, he was blessed with diabetes. That's what ended up happening. So I want you guys to get the concept, talking about degenerative approaches versus regenerative approaches. That's what we're looking for. So now let's say that I've had those 3 cortisones, that hasn't helped very well, and I'm back in the doc's office, okay? Here's what my knee looks like now. And I say to the doc, look, I can't even stand on the darn thing. You know, if I get up and I put any little tiny bit of weight on it, it just hurts like the dickens. So we get this x-ray, what do you guys see? Bone on bone. Who said that? All right, gold star. You saw it right away. So here's the femur. Remember the bone in your thigh? These are called condyles. And I want you to see how this condyle has impacted the tibial plate. And it's actually indented. You see how much whiter it is on this side and this side? So now we have, and there's a little bone spur growing right here. So this guy's got bone on bone, all right? There's no cartilage left. What's the doc's recommendation? What do you think? Replacement. Knee replacement. Correct. You guys are a really good group. You got it. So the very next step is surgery, right? So this is what the degenerative pathway has led to, right? So we've had the knee degenerating over a period of time. We've had all these interventions that are, let me ask you, were they degenerative or regenerative in nature? Degenerative, right? Okay, that's the point I wanted you guys to get, I wanted to get across to you. So knee surgery, it's a hip, same kind of thing. Here's a hip replacement. Here's a God-given original equipment Superman hip, and here's man's hip. Same thing can happen in the shoulder. I know we're talking about the knee because it's an easy one to talk about. But the same loss of cartilage can occur in the shoulder joint, and same kind of result if we go down that degenerative pathway. We've tried all the medications. We've done, how many of you guys have had cortisone injections in your shoulder? Right? Okay. So it helps for a while. Eventually it doesn't. Same concept. Okay? Spine is no different. So here's an x-ray of me. Okay, you're looking right at me. It's not me, I promise. Here's a vertebra. This is where the cartilage, the disc is. Vertebra, disc. These are those little bone spurs. Look at this one down here, guys. What do you think? How does that space compare to this one? Not so good, right? So we have so that same degenerative process that we see happening in the knee joint or the shoulder joint also happens in the spine. So what does the degenerative pathway protocols do? So here's a person who's had chronic low back pain for a long time. They've gone in and they've done a surgical procedure. I have a good friend here in Portland who's a neurosurgeon. I've assisted him in doing these procedures, and this is what we use. Okay, so let's go back and just look at that. So you see, these are called pedicle screws, and you can see them in place, and here they are before we put them in place. So imagine the surgeon and I in there with a drill, and we're drilling holes in bone, and we're placing pedicle screws, and we're torquing it all down to make that low back fuse, okay? So I want you guys to get the image of what we're talking about. So what we've been talking about essentially is a degenerative cascade of aging, right? Remember I said I was 72? So this picture is of my wife Cheyenne and my mom Hilda. And this was taken just before almost her 99th birthday. She passed away just a little while after this picture was taken. Now, when I was 12 years old, when I was in Marrow, my mom was 5'2", okay? 5'2", that was what my mom was. In this picture, my wife Cheyenne is 5'2".
Wow.
Okay, so remember that x-ray we just looked at of the lumbar spine? And we saw how the cartilage degenerated? Mom was 5'2". When she passed away, she was 4'7". Isn't that amazing? So that degenerative cascade just continues. You know, the aging process is not going to change. It's going to keep on happening unless you do something about it, unless you have an opportunity to take some type of intervention that's more regenerative in nature than degenerative in nature. Does that make sense? And so now, for the first time in our lives, we actually have a way that we might be able to do that. So rather than masking pain like we did when we followed that whole degenerative pathway that was linked to pharmacology and surgery, let's talk about a different way. So instead of doing that degenerative pathway, let's talk about the regenerative pathway. That's why you guys are here, right?
Yeah.
All right, so let's talk about stem cells. So stem cells is part of what we refer to as regenerative medicine. And this is a quote I found recently from the National Institute of Health. And it says, regenerative medicine is the process of creating living functional tissues to repair or replace tissue or organ function lost due to age, disease, damage, or congenital defects. Okay? That's a pretty good paragraph. You know what I found so interesting when I ran across this the other day? This paragraph would not have existed 12 years ago. Okay? It absolutely did not exist 12 years ago. Wow, that's exciting. For me, that was very exciting. So stem cells are part of regenerative medicine, and they're often called the master cells of the body because they're capable of becoming any cell in the body. They become new cells. And they can become new cartilage, new ligaments, new bone, new muscle, new heart, new lung. Very interesting. And so they have the potential to repair, restore, replace, and regenerate virtually any cell in our body. So if we're talking about a knee joint who's got less cartilage, stem cells represent a very interesting opportunity. And they work extremely well in orthopedics. So if we're talking about an ankle joint, a knee joint, a hip, a wrist, an elbow, a shoulder, a spine, this is where stem cells truly excel. I mean, they're just absolutely superb. But you know, we've had stem cells working in our bodies all along. Remember I talked about the immortal phase when I was 12? But from the time we were born, stem cells have been busy working every single day in our body. They produce new blood cells, they produce new skin cells, new cells in the lining of our stomach. And the time frames are a little bit different, but the stem cells are busy doing their work all the time. So when I was 12 years old and I was going up the hill on my bike really fast, and I turned to look at my friend, and then I crashed my bike, and I was laying there bloody and scraped up. When I got up, guess who showed up? The stem cells. That's who did it. Those the stem cells came to the rescue and fixed me up. And you guys remember how long it took us to heal when we were immortal?
Oh, yeah.
Pretty darn quick, huh? How about now? Not the same, right? So we'll talk about that a little bit later. But stem cells are unspecialized cells, undifferentiated cells, and they're capable of becoming other cells. So let's talk about what makes them so special. One thing that makes them special is very much like cortisone. They have an anti-inflammatory effect. So that's kind of nice. It's the body's own innate mechanism for reducing inflammation. So when I was 12 and I fell and I got better really fast, stem cells played a role in lowering that inflammation, that inflammatory response. Another thing they do is they fight what's called cell apoptosis or cell death. They help prolong the life of the cells that they're helping to function. Am I going too fast, guys?
Yeah.
Okay. If I do, please just say slow down, okay? Another thing they do is, like I said, they can differentiate and form other cells. So they can become new cartilage, new ligament, new bone, new muscle. And they also self-replicate. And that's a really interesting quality about stem cells, is that when they show up and they figure out what's going on, they have the ability to self-replicate, so there's a lot more of them where they're needed. So how do they know where to go? How do they function? They're attracted to inflammation. And they're activated by injury. And we're going to talk about a concept of how cells communicate with one another. But basically, when a cell is injured, it releases what are called signaling proteins, and they're sort of like the body's way of saying, help, help, I need some help. And the process of communication is what's called paracrine signaling. And all that means is that cells have the ability, biochemically, to communicate with one another. So when that injured cell starts asking for help, the stem cells, through paracrine signaling, get that message, and they start to migrate to the area of inflammation so they can alter the behavior of those cells. So here's a little graphic, and this guy up here is the target cell. Let's say it's the cartilage cell in your knee, and here's the stem cell that has answered the call of paracrine signaling, and it's transferring information from the stem cell to the recipient cell, telling it what to do. So within that soup, if you will, of stem cells, when we're using it in a regenerative medicine capacity, the stem cell dosage contains what are called cytokines, which are kind of like the foremen that kind of tell the cells what to do. They're responsible for that cell-to-cell communication to make sure the cells understand what they're supposed to do. And within that same soup is what are called growth factors. So there's collagen, which is a key building block of cartilage. There are growth factors, messenger RNA, which we just saw in that previous slide where the cells are talking to each other and it's giving it instructions of what to do. Amino acids, carbohydrates, electrolytes, and enzymes. So it's a really interesting cargo, if you will, that the stem cell is bringing with it to get the job done. So let's talk about different types of stem cells. All right. The first one I'm sure you guys have all heard of, embryonic stem cells. Everybody heard that one?
Yeah.
That one goes way back, right? Remember the news in the early days?
Yeah.
Everybody's talking about stem cells. They're like, woo! Look at that, right? Embryonic cells remain illegal in the United States. So if you go to a regenerative medicine clinic and they're telling you that they're going to be providing you embryonic cells, not true. It's not going to happen. They're completely illegal. However, they are being used in research projects. And there's a tremendous amount of research being done in stem cells, especially on the embryonic side, where they're trying to genetically modify cells, sort of program them to take care of particular conditions, all right? And this is heavily influenced by Big Pharma because it would be really cool if we had designer stem cells that could specifically do one particular thing. There's been some work done with this genetic engineering for children's cancer. There's a particular form of leukemia that kills kids really, really badly. 80% of kids die from this particular cancer. Novartis, the big drug company, has modified some embryonic cells and cells from the patient's body. They've tweaked them with genetic engineering, put them back in the kids, and 80% of those kids are still alive. Yay.
Yay.
Right? Pretty good, right? Very good. Very expensive, but very good. The project I like to talk about the most is the London project. So in the London project, do you guys know what age-related macular degeneration is?
Yes.
Okay, it's not fun, right? And when it gets really advanced, it becomes wet macular degeneration, which is essentially blindness. So in the London project, they took two elderly folks in their late 80s, and they took some embryonic cells and they tweaked them to become retinal epithelial cells, and they laid them down at the back of the retina in a single cell layer scaffolding, and both of those patients are now reading 60 words a minute. Yeah, isn't that exciting? So there's a lot of stuff happening on the research side of things, and I think over the next 10 years, medicine is going to be a whole lot different than we see it today. All right, so that's why embryonic cells are of interest, but again, they're illegal for use in the United States. So amniotic fluid is another source of stem cells. They're harvested from amniotic fluid. This is not from abortions or anything like that. It's all donated tissue. They're sent to an FDA-approved tissue lab. They process the cells. They cryogenically freeze the cells, and unfortunately, this is the only downside, with fetal cells, they tend to not survive the cryopreservation. Okay, when you freeze them, they don't survive. But what does survive is the growth factors. There are large amounts of growth factors, and that can make them be very, very valuable. And it can be used in wound repair and localized injury. This past week, I was in Utah. There you go. Why are you in Utah? I was in Utah to have an implant procedure done by my guy, who is one of the top guys in the country, and he used to live in Portland. I've known him for years. Anyway, so I traveled to Utah because my front tooth was wobbly. It was ready to come out. Long history, fight when I was 15, but that's okay. But what happened was, while I was there, he extracted the tooth, and he did some, there was a big cyst behind it, and he had to remove that. And then he had to do some bone grafting, and then he did an implant. Oh my gosh, wow. Interestingly, when we was all done and we were sitting around chatting, he said, you know what I did, Doc? He said, I used an amniotic tissue membrane to promote healing because of the growth factors. Right? Interesting, right? He took some of my blood, spun it down to get some of my platelets and my plasma, right? And then used that and the amniotic tissue membrane to promote healing.
Without telling you?
Excuse me?
Without telling you?
Yeah, without telling me, because I trust the guy, you know, totally, right? So I'm in the chair, he's figuring out what he wants to do, he does that, all right? Here's what's really interesting. And Dr. Dryling in the back, he can confirm that this is true, okay? I had zero pain the very same day. By that, I mean, I was a little, you know, from the procedure, but later that day, that was it. Zero pain, and it's completely healed. And what's today? Today's Wednesday, right? It was a week ago today that I had the procedure. Okay? And you guys eat bagels? Yeah, I had a bagel yesterday. But I'm just using that as an example of what amniotic tissue membranes can do. Okay? So here's another source of stem cells: placenta and cord blood, often called Wharton's gel. So again, these are donated placentas. They're donated umbilical cords. It's not from abortions, not from Planned Parenthood. And placental cells are often used in chronic blood-related disorders like sickle cell anemia because they have a very high amount of what are called hemopoietic cells. And they like to form blood cells. Like I said, the umbilical cords are donated. They go to tissue banks. They process the umbilical cords. They're trying to get those stem cells out of them. Regenerative medicine clinics that use umbilical cord blood, we purchase those cells from tissue banks, and they come in what are called aliquots, which just means a dosage, and typically there are about 800,000 to 1 million cells in that aliquot. Okay? I know that sounds like a lot. Now, there is some upside and there's some downside with umbilical cord blood. If you have a very early stage degenerative process, let's say you're young, you sprained your knee a little bit, it's a little nasty, that kind of a dosage of cells is fine. They don't self-replicate in the host the way our own cells do, so that's one downside. They're not approved for IV infusion. In other words, we can't provide them to you systemically, and we'll talk more about that a little bit later, why that's an issue. Basically, the cells, when they come from umbilical cords from a tissue bank, they screen them for disease. They screen them for about 7 to 15 different viruses, depending on which bank we're talking about. It's not an all-inclusive list, but it's meant to try to provide some degree of safety. These are the two most popular that are used in regenerative medicine clinics: bone marrow and adipose-derived stem cells. Everybody know what adipose is? It's a nice way of saying it, right? Yeah. So bone marrow's been around a long time. I mean, we're probably 35, 40 years we've been doing bone marrow transplants, and we'll talk a little bit about that first. So the main type of cells we find in bone marrow are hemopoietic cells that I mentioned just a brief minute ago, and they really like to make blood cells. They really, really do. That's what they love to do. The largest amount of cells found in bone marrow are hemopoietic. The other type of cell that's found are what are called stromal cells, and they like to become fat, cartilage, muscle, bone, but there's just not as many of them. So bone marrow cells are most often used in blood dyscrasias like leukemia. That's generally where we're going to go. We're going to go to bone marrow. The stromal cells, like I said, they're often, the count is less, and so if we wanted to use them in an orthopedic case, we have to not only harvest them, but then we have to culture expand them so we get enough cells. So there's sort of a waiting period in between the harvesting and the actual treatment because we've got to get enough cells to actually do the procedure. So adipose has become very, very popular. It's our favorite one. for a couple of reasons. One is there's an incredibly large amount of stem cells found in our adipose tissue. Who knew? Some years back, we started to realize that all of us were walking around with these big warehouses full of stem cells. Now, some of us have larger warehouses than others. Was that tactful? I tried to be tactful. Okay, so
would getting liposuction be extremely wasteful then?
hold that question. So they have large amounts of cells, and they're really easy to access. Sort of liposuction, but really a mini liposuction. We'll talk more about it. It's a very simple, in-office, one-day procedure. Very, very easy. It's highly effective in orthopedic and systemic disease conditions because there's just so many cells. The cell count is so high that it's a really ideal source for stem cells to be used in treatment. So let's just compare the two a little bit. First of all, it's a lot less painful to harvest adipose cells than it is bone marrow. Anybody here have bone marrow aspiration? You've heard of it, right? Okay. So anyway, it's much easier to do a mini liposuction. The concentration of cells in the fat tissue, like I said, is significantly higher, as much as 500 times greater amounts are found within fat tissue than are found within bone marrow. So that's another great reason. There's fewer white blood cells, so there's less pain and inflammation involved, and it's safer. It's a simpler procedure. There's not as much downside risk of infection as there is with a bone marrow aspirate. And basically, another real good reason is that fat-derived stem cells have less senescence. What does that mean? It just means that they live longer. They have a longer lifespan than bone marrow cells. Bone marrow cells don't have as long a lifespan as fat cells. So for us, adipose makes a lot more sense. So we've talked about a lot of different cells, and I just want to sort of give you guys a little guidepost as to which type of stem cell would be better indicated for a particular condition. So we talked originally about amniotic and placental umbilical cord cells, and we mentioned about wound healing for amniotic membrane. We talked about early stage degeneration in joints, because you guys are all radiologists now. Remember those x-rays we looked at? So remember phase 1? Good candidate. Phase 3, not so much. And again, one of the problems with those types of cells is we can't do IV infusions with it. It's an off-label use. There are clinics that do it, but trust me, it's an off-label use. You're not supposed to do it. So bone marrow, like I said, is really popular for blood dyscrasias like leukemia. Absolutely the cell of choice. But for orthopedics, again, the cell count's a little bit low, and so we're going to have to culture expand. Adipose is really ideal for orthopedic joints like the knees, the hips, the shoulders, the spine, systemic diseases, autoimmune diseases, and neurodegenerative diseases. So we're talking things like Parkinson's, COPD, Crohn's disease, lupus, all that good stuff. Multiple sclerosis, all that kind of stuff is really, adipose is a great cell to use. Osteoarthritis and rheumatoid arthritis incredibly well. Later on, we'll talk about results. We'll talk about efficacy with some of these conditions. But I want to give you a sense of where these particular cells fit in from a clinical perspective. So this is kind of interesting. When we were young, the stem cells that were free circulating, our bone marrow, remember when we talked about when we were mortal, when we were all 12? Our bone marrow was constantly releasing stem cells, free circulating stem cells, and we had pretty large quantities. So when I did fall out of that tree or fell off my bike, the response was pretty quick. But that number kind of decreases as we age. It goes down significantly, and the stem cells age, and they're just not as vibrant as they were when we were young. So here's a little chart. When we were young, when we were fresh out of the box, 1 out of 10,000 cells were stem cells. But as we hit age 50, 1 out of 400,000. And as we get 80, 1 in 2 million. So that gives you a sense of when it comes to free circulating cells, the number has really dropped off a lot. And that's why at 72, when I fall off my bike and I get scraped up, I'm not ready to go the next day. Right? Any of you guys ready to go the next day? Not, right? Well, that's part of the reason, is that we've really dropped off. All right? So that's one of the exciting things about regenerative medicine. Remember I said we had this big warehouse? Well, that's interesting. So if I could take a bunch of them out of the warehouse and deliver them to the site of injury, then I have a chance to make a big difference. So let's talk about how we get it. Bone marrow. So bone marrow aspiration is done. This is your pelvic bone. It's a portion of it called the iliac crest. We drill a hole in the iliac crest. We go in there and we scrape the cells out and we aspirate them out. And like I said, if it's for an orthopedic condition, we're going to have the culture expand. Does that sound like fun? No. Well, if any of you guys said yes, I'm going to report you guys. So placenta and cord blood, venous jelly, very, very easy to get. Remember, they're from donated tissue. It's gone to a tissue bank. They process them, they package them, and they send them to the clinic. So for you guys, it's relatively easy. Lots of the cord blood cells are hemopoietic, the ones that want to form blood cells, and the other load are mesenchymal stem cells, like the ones from fat tissue. And nothing wrong with them, except, like I said, cell counts are low. They have been screened for disease to some degree. We're a little uncomfortable with the degree of screening because we just think there's a heck of a lot more potential risk. And our experience with them was that we weren't getting the same results. We weren't getting the same consistency. We might use them on one patient, have great results. We use them on another one, not so good. The body seemed to reject them. So we kind of moved a little bit away from that. Adipose, this is just a little graphic just to show you your skin and your fat layer in the love handle area, the flank, and just a little suction syringe to just remove them. And we'll talk more about that later. I just want to give you a little graphic just so you can sort of imagine it. So we've been talking about degenerative and regenerative medicine. We've been comparing the two. And so let's think about it now. Let's think about what kind of options we have if we have a condition that's bothering us. Well, one option is to do nothing. Are any of you guys out there do nothing? Yeah, I got one. Yeah. No, I mean, it's an option, okay? It's a viable option. I don't know if it's viable, but it's an option. We can always do that. I'm not a big fan of that. You know, I'm not like rolling the dice that if I do nothing, it's going to go away. You know, so I once saw a sign in front of a doctor's clinic. It said 5 dangerous words, maybe it will go away. That was fun. That was very fun. So another choice is to just take more medication. So we know that there are side effects with medication, but some people say, you know what, I'm just going to take the chance that that side effect is not me. You know, I'm going to be the person that doesn't happen to, or I'm just willing to live with the downside risk. Some people will choose surgery for all kinds of reasons. And for us, we're like, well, no, we're here to tell you guys about regenerative medicine. So we're gonna obviously emphasize that. But let's go over some of these other procedures and let's just get the true facts of what's going on. So what's the true cause of surgery? This is a knee, by the way. Okay, it's a knee replacement. So pain, obviously. Surgery is not simple. It's a major procedure. There are often 3 to 6 months of healing time required, rehabilitation. There's no guarantee of results, as always. There's a high percentage of failure and complications. They don't always work out so well. We've seen a couple of patients in clinic recently where they've had knee replacements done more than once the same knee. So that's part of the risk. So 50% of patients that undergo these types of surgeries have to have repeats. And it's expensive, let's face it. Surgery is not cheap. Sometimes insurance pays for a major portion of it, but oftentimes people get stuck with a pretty big bill as well. But what's the real cost? I mean, to me, remember me talking early on about quality of life? That's what I think is the real cost of surgical procedures, quality of life. Because we've seen how that impacts people's lives, especially the surgeries that were not successful. So spinal surgery has a really poor record. You guys probably know that anyway. But here's a study that was done in Ohio. 1,450 workers' compensation cases. They all had a similar diagnosis of degenerative disc in the back, disc herniations, radiculopathy, which is pain into the extremities. Half of the patients had surgery to fuse it. Remember that X-ray we looked at with the pedicle screws? So half of them had that. And the other half did not, even though they had the same symptoms. Here's the outcomes. After 2 years, only 26% of the people who had the surgery were able to return to work. What do you guys think? You're bad, right? It's not a good outcome. It's bad. Interestingly, 67% of the patients that didn't have the surgery were able to return to work. But what's really interesting is that there was a 41% increase in the use of NSAIDs and narcotics, and particularly opioids, in the patients that had the surgery. Okay? So I'm picking on that whole degenerative pathway. Right? You got to humor me while I do that. Okay? I want to pick on it a little bit. There's a lot of risk in surgery. There's bleeding problems, blood clot formations. Sometimes people have difficulty with breathing afterwards. There's infection rates to be dealt with. There are death rates. TKR, part of my translation here, total knee replacement. It's not always a great outcome. And the increased use of drugs in those patients that have had these procedures. So again, I'm emphasizing we don't want to just mask pain. We want to say, is there something that we could do in a positive way that can actually put this back on track? So let's go over some examples of what stem cells are capable of doing. Here's an X-ray pre-stem cell. This is post-stem cell. I believe the spread is 4 months. Okay? So I know you guys are all radiologists now. Look at the joint spaces. Same knee. Okay? This one's a little bit harder to see. This is a 2-month window. So look at that, compare it to that, compare it to that, this one to that one, this one to that one. It's a little bit hard to see. This is my favorite one. This is an 8-month window, all right? So what do you guys think about this knee? I love you guys. You guys are like real radiologists now. It's a great class. I like it. All right. So you can see it's really close to bone on bone, isn't it? Okay? Now sometimes a patient will come to the clinic and they'll say, my doc said I'm bone on bone. And I always say, bring me your film, I want to look at it. Bring me your MRI, I want to get a look at it. Because oftentimes a radiologist will declare it bone on bone when it's actually not. All right? So what we don't see on here is we don't see this condyle impacting the tibial plate. And we don't see a tremendous amount of increased whiteness in the tibial plate. And we can see a little blackness in there, right? Okay, good. I want to make sure we're all reading the same film. So this patient had his stem cells harvested. An injection was made into this side of the knee, the open side, the bigger side, and that's strictly for patient comfort. And the stem cells go in and they migrate. Remember our whole lecture about migration? So they migrate through the joint, and they what do? They use paracrine signaling, don't they? And they communicate back and forth to the cartilage cell. They release their cargo that tells the cartilage cells what to do, and here we are 8 months later. So, what do you guys think this patient had a change in quality of life?
Yes. Oh, yes.
Right? That's what I'm trying to drive home to you guys today. This guy was not able to go on a hike to Silver Falls. Now he can. That's the point I'm trying to make about the difference between degenerative approaches to health and regenerative approaches. This is not from our clinic, this is from another one, but they're very interesting slides. This is a grade 3 osteoarthritis in the knee, and you guys can see, because I know you're all good radiologists, pretty close to bone on bone, right? Very, very close. Here it is a year later. So we've got a little bit of darkness showing up in there, right? We've got a little bit of space, and that's a great outcome. This is an MRI of the knee with a grade 2 osteoarthritis with a chondral flap. There's a chondral defect here in the MRI, and this is 6 months later, and that defect has been reabsorbed, and it's healed. This is a grade 3, further along the trail, and he's got a subchondral cyst in here, and 18 months after stem cell therapy, the cyst has been resolved. Yay! So people always ask us, well, what's the success rate? Okay? Is that something of interest? Right. So remember I said we're part of the Cell Surgical Network, and all of our patients that get treated in all the cell surgical clinics around the country all feed into a common database. Patients are all part of a study. We follow up with them. All that data is gathered, and this is right off the Cell Surgical Network site. And so what we've got is, jumping ahead. So with knees, we have an 83% across the board improvement ratio. With hips, 80%. Shoulders, 81%. In the spine, in the cervical spine, which is up here in your upper back, your neck area, 85%. Thoracic is your middle back, like between your shoulder blades, 83%. And in the lower back, in the sacral area, about 76%. In our clinic, we found pretty much that those numbers are pretty consistent with what we have found. Here's a degenerative disc patient. I get asked that a lot. This was his pain levels, and this is 2 months down the line, 6 months down the line. And so we've gotten some increases in functional capacity and decreases in pain. We mentioned earlier about neurodegenerative type diseases. So multiple sclerosis is something that we actually do treat in our clinic. We use stem cells, and we do it by IV infusion. Remember my remarks about umbilical cord when I was picking on it? Okay. And I said, one of the downsides is we can't use IV infusion. With multiple sclerosis, with Parkinson's, with COPD, with those types of conditions, we want to provide the stem cells systemically. Remember the slide about how they migrate and they seek out problem areas? So in the case of multiple sclerosis, we're going to harvest the stem cells, we're going to bank the cells so we can use them more than once, and we're going to IV infuse the patient. We had a case recently, a gal in her mid-30s from Salem, I believe, and we treated her about a month and a half ago, and she's still in her wheelchair, but she's got full bladder control now. That's exciting. That for her, that's life-changing, quality of life issue. Again, life-changing. So success rates across the network with MS are sitting at right around 74%. These are a couple others. Crohn's disease, we've got 60%. Rheumatoid arthritis, look at this one, 87.5. That's one of my favorites. We actually treated a young patient yesterday in our clinic. He's 17 years old, he lives out in the gorge, and he's got severe Crohn's disease. He's had it for 5 years, or he's only 17 years old, had it for 5 years, and we just did an IV infusion with him yesterday, and I hope that the next time I'm back here in Vancouver to the talk, I hope I'll have something super positive to say. He's a really, really nice young man, and we're really hoping he's going to do better. Here's some other ones. Stroke, 55%, Parkinson's, close to 65%, and multiple dystrophy, 64%, and CP, cerebral palsy, close to 78%. And right away I can present you with Oz. Remember Oz that we saw in the film? Yeah? What a great kid. He's a really great kid. The last time I saw him, which was the first week in June, I think it was, he was actually his dad called him up, and he actually said a few words, which is just amazing. I mean, really, this kid was completely nonverbal. You know? And as you saw in the film, his verbal skills are not that great yet, but he's got some, which is just amazing. So here's lupus. Lupus at 80%. Inclusion body myositis, unfortunately, 16.7%. We have not figured this one out. This attacks the muscles, and we have not figured this one out. Hopefully we will. Hopefully we'll figure out a protocol that actually works. But right now, thank God, it's an extremely rare condition, but we have not figured that one out yet. COPD, you guys know what that is? Chronic obstructive pulmonary disease. These are the folks you see walking around the mall with the oxygen tube, you know, and they're pushing oxygen around, okay? It affects the lungs. They have tremendous difficulty in breathing. One of the ways we score them is what's called the 6-minute walk test. And again, here's my good old favorite thing, quality of life, right? This is not a cure. Stem cells are not going to cure MS. They're not going to cure Parkinson's, not going to cure COPD, but it's going to impact quality of life, all right? So those kind of cases, unlike orthopedic cases, are going to require multiple treatments over a period of time. So here's a COPD case. At baseline, the day treatment, his walk score was 150 meters. And here it is 3 months after stem cells, he's right at about 225. So what has it done? It's improved his quality of life. He's lowered his oxygen usage, and he's able to have higher functional capacity. And that's a quality of life issue, and one that we're real happy for. So this is neuropathy. You guys have heard of neuropathy? Okay. So in neuropathy, this is a blood flow study of the lower limb, and you can see that there's not much blood flow throughout the leg, is there? So here we are about 6 months later after stem cells, and you can see that there's been a marked change in the blood flow. So one of the things that stem cells contribute to is what's called angiogenesis, okay? And all that word means is that stem cells promote new blood vessel formation. So when you have a neuropathy patient, If you can increase blood flow to the extremity, that extra blood flow helps regenerate nerve tissue, and we get a much better outcome with a neuropathy patient. So oftentimes they'll say, I no longer have burning in my feet. I no longer have pain in my legs. I'm able to walk through Costco, which is a great idea, right? Do you guys like to go through Costco? I do. I always want to see what's for lunch. Here's another one. This is another neuropathy patient, and you can see there's a lot of venous coagulation down here at the ankles, and here it is 8 months after stem cells. Nice blood flow throughout the lower extremities, and all that venous congestion is gone.
Is that one treatment?
Yes. Yeah, that's one. Now that's a good question, because with peripheral neuropathy, if we're lucky, it's one treatment. But we might, in the future, have to go back. Okay? And that's IV. It's IV and local. All right, so down in your ankle area, there's a little compartment in there called the tarsal tunnel. And so we'll oftentimes, after we get your cells, we'll go into the tarsal tunnel, we'll do a deployment there, and we'll balance with the rest of the cells by IV infusion. Good question. Here's radiation necrosis. And this is not a great picture to look at, I'm sorry. But this was a person who was going to lose his leg. Okay, critical limb ischemia. And they went ahead and decided that, you know what, I can always cut my leg off. Let's try to do stem cells ahead of time. So they did stem cells locally all around this wound area. And here it is 8 months later. That's exciting.
Yeah.
Because, you know, once you cut that leg off, it ain't coming back. Okay? So here's a young fellow, 15 years old, with severe eczema. You can see that he had stem cells harvested, and he was provided stem cells by IV infusion. Here he is a couple months later in salt water. Any of you guys have severe eczema going in salt water? Not fun. Not fun at all. So that's a great outcome. Here's Mary, Barb, I'm sorry, this is Barb. She's an MS patient, and she was wheelchair bound, and she's not walking normally, but she's able to start working with her physical therapist again, and that's very exciting. This is Graham. He's a spinal cord injury patient from up in Seattle, and he's also had a procedure done, and again, he's got a long way to go, but he's starting to show some early improvement, and that's exciting because, again, it's a quality of life issue. Graham may never be on the ball field with me, ever, okay? But if we can change his life even a little bit, that's a really big thing. So here's my disclaimer. Stem cells are not a silver bullet. I'm going to take you back to radiology class for a minute, if you don't mind. You guys remember this x-ray? So what did you guys say about it? You said bone on bone, right? So if you show up in our clinic and you bring us your images, and you tell me that I can't stand on that knee, and we look at your images and you're bone on bone, you know what the treatment of choice is? A hug. I got to give you a hug, and I got to say, look, there's no base scaffold of cells left, so there's nothing to build upon. So if in fact you are in a bone-on-bone scenario, we're going to have an adult moment together as we look at those films, and we're going to have to make a different decision because you're not a regenerative medicine candidate at that point. Does that make sense? Yeah. Okay. But on the other hand, if you're not bone on bone, then there's reason for hope. So a little bit more about Solutions. I mentioned in the very beginning, I called ourselves a Center of Excellence clinic in regenerative medicine. They were part of the Cell Surgical Network. And I wanted to just say a little bit about why that's true. The Cell Surgical Network, like I said, is the largest group. There's well over 100 clinics involved, and let's talk a little bit about them. The Cell Surgical Network is the leading provider of stem cell therapy in the United States. They've been a pioneer in stem cells. They've been doing it since 2008, and they're the only group in the U.S. that operates under what's called an IRB. Anybody here know what that is? So an IRB is an institutional review board. So basically, under the auspices of the review board, every patient's care is closely monitored. The data is all sent into the NIH and the FDA, and all the clinics that are part of that network all use the same protocols. We all follow the same. If you were to walk into one of their clinics in LA, and you walked into their lab, it would look identical to our lab. Okay? and the procedures would be the same. The harvesting of the cells, the way the lab is processed, all that would be the same. So for us, Cell Surgical Network has revolutionized the way stem cells are done, the way they're harvested, the way they're processed, the way they're concentrated in the lab, and the methodology of how we actually do it. This is really very important because of cell counts. You remember way back when we were talking about umbilical cord, and I said that the cell counts are like 1 million cells? Okay? If I harvest your cells, we may get as many as 60, 80 million cells. Okay? Now there's lots of ways to harvest adipose tissue, and there's different ways to process it. If you use what's called a fat filtration system, it takes about 20 minutes, and you get about 2 million cells. The protocols that we have to follow with Cell Surgical Network take 1.5 hours in the lab. However, instead of 2 million cells, now I have 60 million cells or 80 million cells. That's the upside. That's where the upside comes. Because what we've learned over the years of doing this is that cell counts are incredibly important. The more cells you have, the greater your chances of having a positive outcome. So all the clinics that are part of the Cell Surgical Network, we all adhere to that, and that for us gives us a real advantage. So the protocols are all proprietary. It is a mini liposuction. My friend in the back used the word liposuction earlier. It's a mini liposuction. I'll describe it in a little more detail in a few minutes. It's much easier than bone marrow aspiration. There can be some localized bruising, tenderness, and swelling at the site of harvest for usually about a week or less. Like I said, we get really high cell counts because of the protocols that we follow, and we really believe that that's a real positive. Other systems just get a lot less counts, and for us, that's a drawback. We're also allowed to cell bank. Now, the Institutional Review Board process allows that. So if we have a patient that has Parkinson's, for example, or a patient that has a really severely degenerative knee, and we think we may need more than one procedure, cell banking gives us the opportunity to do that. We can harvest twice as many cells, we can send them off to a cell bank, and we can have them culture expand them, so we have access to them in the future. And that's a really big plus for us. Let's go back a little bit to talk about the components that are in there. When we do harvest your cells, and we do process them in the lab, the net result of that harvesting and processing is what's called a stromal vascular fraction. And it contains those cytokines that we talked about earlier, that paracrine signaling, all that communication. The SVF that we've been able to put together has very, very high cell counts and high amounts of the cytokines and the growth factors that we talked about earlier, the collagen, the messenger RNA growth factors, the amino acids, the carbohydrates, the electrolytes, and the enzymes. So this is a list of some of the conditions that have been treated across the Cell Surgical Network. I'm not going to bother reading through it all, but it's very, very extensive, as you can see. And in our clinic at Solutions in Vancouver, we've treated most of the conditions that you see on this list. So here's how we actually harvest it, right? So it's a simple one-day procedure in the clinic. You come in, they lie you on a procedure table, create a sterile field, give you a localized lidocaine injection. Anybody ever had one of those? Mm-hmm. I had one in Utah last week. And lidocaine stings, right? So we do that little lidocaine injection. Your skin numbs up. We make a 1/4-inch incision in that area. And then we go right back through that incision and with more lidocaine, and we put about 50 cc's of lidocaine. That's generally right in what we all call the love handle area, your flank area. We're going to put about 50 cc's in there, and that's going to sting. That's the worst part, I promise. Just the lidocaine, it stings. I haven't figured out how to make it not sting. Then we go right back in for that same 1/4-inch incision with a suction syringe, and we just remove a little less than a stick of butter. Okay? So this is not a sculpting procedure. Don't ask us to sculpt you, okay? Wrong clinic, okay? It's not what we do. We just want to get what we need. Okay? And that procedure takes about 15 to 20 minutes. Some folks, if they're really, really thin, it might take a little bit longer just to get enough cells, but based on average, we're talking about 15 to 20 minutes. So once we get you up off the table, we've put a Band-Aid on the incision, no stitches. Okay, that's how minor it is. It's a mini liposuction. We get you up off the table, we put an abdominal compression belt on you. Remember us talking earlier about localized tenderness, bruising, and swelling? Well, we want to keep that to a minimum if we can. So we're going to ask you to wear that kind of a belt for about 4 or 5 days. Guess who doesn't like to wear the belt? Right. Which gender?
Yeah.
No, the women actually are pretty good at that. The men are a little bit harder, okay? But you know, it's all that testosterone we have going to us. But I always recommend that you guys wear it because it really will cut it down. And so we'll get you up off the table, we'll get you fitted with that belt, and then you have about an hour and a half to relax. You can go have lunch, you can watch a movie, you can just chill out in the clinic and relax. And while you're doing that, we've taken your cells into the lab. We've started to process them with the cell surgical protocols, and that takes about 90 minutes. If we were doing fat filtration, it would take about 20 minutes, and we'd be done, but we just wouldn't have the same amount of cells. So it takes about an hour and a half, and we count the cells to ensure the cell count and the viability of the cells. So how do you think we count the cells? You think we lay them on the floor and just... So we have equipment, you know, we have cell counters, and we prepare slides, and we count the cells, and we check the viability. And viability is very, very important, you know, and I'll make some comments. I'm not trying to pick on anybody. But if you're a chronic smoker, if you're significantly overweight, if your general health is really poor, if your nutrition stinks, your cells are probably not great candidates. Make sense? Okay? So if that's your reality, we may use a different type of procedure, okay? But that's one of the things we're looking for. We want to look at your cells, we want to see how many did we get? Did we get 40 million? Did we get 80 million? Was it 91% viability? Was it 87%? And this is interesting because let's go back to umbilical cord blood again, okay? If we get umbilical cord blood, the viability is going to be 95 to 98%. That's great, okay? And so one of the arguments against using your own cells is that, well, your cells are much older and they're not going to be as viable. To some degree, that's true. But the quantities of cells in adipose is extremely high. And so if we get a really high cell count and your viability is 87% versus 95, or it's 91% versus 98, I'll go with the 80 million cells at 91% any day of the week. Does that make sense? It's sort of common sense. So here's a slide showing you how we deploy it. Let's say it was the knee that we've been focusing on. So we bring you back in the clinic after that hour and a half is up. Maybe you went and had lunch, maybe you watched the movie, you're back in clinic, we bring you into the procedure room. We use a little, we use a little ethyl chloride spray just to numb the outside area a little bit. We use a guided ultrasound so we can look inside your knee so we know which side we want to go in on. And we'll deploy the stem cells directly into that enclosed capsule joint. And then we'll give you the balance of them by IV infusion. You're starting to see why I kept emphasizing the IV infusion issue before? Okay. We want you to get as many cells as we can into the affected joint capsule, and we want to give you a systemic distribution of the balance of your cells because we have so many of them. And we know they're going to migrate. So it's not unusual for us to have a patient say, hey, thanks for treating my knee. By the way, I never told you about my shoulder. You know, I had a rotator cuff tear. And my gosh, it's better. Okay? I'll give you a good example. Okay, we had a patient recently, a couple of months back. He's an 82-year-old gentleman. He had his right knee replaced twice. Okay? So you know, the first one didn't go so well, right? Had it replaced twice. Now his left knee is really bad, and they want to replace the left knee. So he came into the clinic. So I looked at his x-rays with him, I examined him, we went over it, we decided to harvest his cells, cell bank, so we'd have them available in the future if we needed them. We injected into his left knee and an IV infusion. Can't go into the right knee because what's inside there? It's all metal. There's no joint capsule anymore. It's metal on metal, right? So we didn't go in there. So into his left knee, IV infusion. 30 days later, he came in clinic for his follow-up, and here's what he said to me. He said, my left knee is like brand new, really good. He was showing me how great it is. And then he said, hey, remember the IV infusion? He said, this right knee is not as good as the left, but it's better than it was. So remember we talked about the special properties of stem cells, and we said they're anti-inflammatory? So it helped lower the inflammatory post-surgical discomfort that he's been having. So that's really interesting. So it's oftentimes a simple one-time procedure. You know, remember cortisone? How many of those do we have to have? A bunch, right? Okay, so this is not like that because it's not degenerative, it's regenerative. So oftentimes it's a simple one-time procedure. The one thing that we like to say is we prefer after your procedure, if you have one, that you don't use prednisone and other anti-inflammatories for about a month if you can do it, because they're anti-inflammatory. And stem cells react to inflammation, okay? So we want to make sure that that signaling has a chance to truly happen, okay? So I'm often asked about safety and adverse reactions. So what these charts basically say is that there's a 0.3% incidence of infection at the site of hearts, okay? And who do you think makes up that 0.3%? The folks that just don't take good care of follow-up instruction, okay? It's very, very low. And the other adverse that we have is we have about a 1% incident of localized tenderness, bruising, and swelling lasting more than a week. Okay? That's it. That's the downside. Now, there have been, just talking about stem cells in general, there have been 3 very tragic cases in the United States that had to do with macular degeneration. Clinics took stem cells, they directly injected them into the eye, trying to help patients with macular degeneration, and those 3 patients all had bad outcomes that ended up in blindness. So nobody's doing that. If you have macular degeneration and any regenerative medicine clinic tells you they're going to do something directly into the eye, please leave, okay? That's it. Those are the 3 worst cases. Otherwise, there are no adverse reactions whatsoever. You guys ready to see a couple of testimonials? You have any interest in that? Okay, I have 2 of them. I'd love to be able to show you guys these. Let me see if I can figure out how to do it.
Tigard, Oregon, Kay Crawford. Well, I have several. I had Parkinson's and I wanted treatment for that. And I had my right knee, I couldn't bend with any weight on it. And so when I went upstairs, I'd have to go 2 steps each stair. It's been a couple of months, I think, and I was really surprised. On the 3rd day after my procedure, I woke up with more energy than I've had in years. My right knee didn't hurt when I bend it. So now I can go upstairs like that instead of 2 steps for each stair. And my partner noticed that I was taking big steps instead of Parkinson's shuffling steps. We saw in the paper that there was going to be a seminar. We went to the seminar and we were impressed. And so we made an initial consultation appointment, and we're even more impressed when we got here. It just seemed like people knew what they were doing, and they're very friendly and a nice atmosphere. I'd say try it. I think it's working.
My name is Judy Rund, and I am from Litchfield, Washington. I have been having a lot of low back pain, bladder problems, and all kinds of issues related to my multiple sclerosis diagnosis. I had my procedure on September 6th. I currently have absolutely no low back pain. I have, my vertigo's not as bad as it was. I'm totally happy that I had this done. I think that overall, my not having the back pain, and I feel like my brain fog that I had is a lot better than it was. I found Solutions in Vancouver through an article in the newspaper that my dad gave me. I did a lot of research online. I actually was slated to go to a place in California, but I liked the website information. I went to your seminar and just fell in love with what I saw there. That's why I chose Solutions. I was real iffy as to what I was going to do, and that's why I did my research. I made a decision that was best for me. I highly recommend this for anybody. Go to the seminars, come in and talk to the staff and the doctors here and make your final decision. But I honestly don't think you can go wrong coming here.
So reasons to do stem cells, they only work if you actually do it. Quality of life is the point I've been trying to make to you guys all day. I think that's what it's all about. And stem cells can truly help you take back your life if you're an appropriate candidate.